Hello, everyone, and welcome to Advanced Trauma Module 1. My name is Alexandra Rowe. I'm part of the lead faculty here at CE Solutions, and I will be your instructor for today's class. Today, we will be discussing triage as well as traumatic brain and spinal cord injuries. The first section we're going to go over today is principles of triage. Our objectives for this section, we're going to define mass casualty, triage, and the principles of these concepts. Then we will describe the START method of triage, including the use of the color code, and then define the mnemonic RPM. So to start this off, guys, what is considered a mass casualty? As we know, any type of event that has the potential to produce multiple people who are injured would be considered a mass casualty. But who really puts the number on how many casualties count as an actual mass casualty? Because if you think about it, an incident in, say, Dallas, where there's a lot of assistance, a lot of ambulances and fire trucks there, it's going to be a lot different than, say, where I come from. So I used to work in rural West Texas. The county was 1073 square miles, and the population was about 8,000. We only had about 2 ambulances that were on full-time for the entire county. So our service was depleted quickly when incidents would happen, and we would have a mass casualty faster than, say, Dallas would. So a mass casualty is really any incident that occurs and presents us with more patients than we can handle. It really depends on department size, how many resources you can get to you. For example, since we were a small department, we had to call other counties for them to come assist us when even like small car accidents. We'd have maybe a 2-car accident, but we would have, 3 or 4 patients. If we had an ambulance out on another call, we would have to call a service from another county to come assist us. So it really depends on where you work and what your resources are at that certain time. Triage. So we have obtained a lot of our knowledge in medicine from war times, right? Triage specifically came from the Surgeon-in-Chief to Napoleon's Imperial Guard. So triage is translated from the French word trier, which means to separate, sift, or collect. Back during Napoleon's time, on the battlefield, there were, of course, many injuries. The Surgeon-in-Chief decided that we needed to kind of sort out these patients to see who is more critical and who did we need to work on first. They would separate people and bring them to different battlefield aid stations behind the front lines. So we know that triage isn't always an ongoing process. Just because, say, you triage somebody and they are a yellow tag right now doesn't mean they could potentially end up being a red later on. That's why we always need to keep our head on a swivel. This is an ongoing process. Starts at the point of injury. It may change once the patient actually reaches the treatment area, and then again once the patient enters the hospital. Because we all know that injuries can, progress to something more severe. The START triage method is widely used in the civilian EMS world. What does START triage mean? So it means simple triage and a rapid treatment. Incident command and triage. Triage is a small part of the National Incident Management System, or NIMS. So what is NIMS? NIMS was structured for the management of a large-scale or multi-jurisdictional incident. When the federal government needed to get involved in, like, say, local level type of events, that's why NIMS was created. That way, anybody and everybody could be trained the same way. So, say a hurricane happens. I'm here in the great state of Texas, and we get hurricanes often. So say a hurricane happens and we have people from all over the United States wanting to come assist us with hurricane relief. It would be very difficult for those who weren't trained like we were to actually assist us. They may actually become, a patient themselves, and we want to prevent that. So if we can have everybody on the same page and nationally train all the same way, events go a lot easier. They go smoother. So this does happen, NIMS does happen at the federal level, state, and local levels. And did you know those who seek like federal funds, say from like Homeland Security, they actually have to prove that they are NIMS compliant. The cool thing about NIMS too is you can actually go on the FEMA website and take those classes for free. I do recommend that you do those classes live in like a group setting. They're a lot more fun, but you can get those free resources and training on the FEMA website, which FEMA is the Federal Emergency Management Agency. Typically, when you arrive on scene, the responsibility of triage falls upon the incident commander. I'll just give you an example here. Say you get dispatched to a multiple car pileup, and right now it's just you and your partner on an ambulance. So you show up on scene, you only have you and your partner, but you see there's the potential for multiple casualties. So what happens? Who becomes the incident commander and who becomes the triage officer? Typically, like where I come from, of course, this could be different where you guys work. Usually the first on scene with like the more experience or higher level certification is usually the incident commander until somewhere of, a higher ranking official arrives on scene to assist. And then the second person ends up being the triage officer. You guys would both make your 360 walk around the scene, evaluate everything, and that's when you would be able to call for extra resources if needed. Now, in larger incidents, an EMS officer may be appointed. So there's a specific person who has this job duty, and then the triage officer would actually report to them. So that's usually during like much larger scale events. And don't be surprised that, again, like if you were to travel somewhere to assist with, say, like hurricane relief or anything else, that the main service in that area, they may actually ask you to prove your NIMS training. For example, Hurricane Katrina, when that happened a long time ago, it was pretty chaotic because there were a lot of people there trying to help, but not everyone was trained the same way. So unfortunately, they had to be rescued because not a lot of them were, water rescue trained and ended up becoming patients themselves. There are a lot of people on standby too to help, but they ended up telling them, hey, just go home, because we don't want to risk you guys getting hurt. Okay, START method of triage. Like I said, this stands for simple triage and rapid treatment. It actually was developed in California in the 80s by Hoag Hospital, as well as Newport Beach Fire and Marine Department. And they decided that it would be easier to kind of code people by color. When we triage people, it's a little difficult to say, everyone with bleeding, go over here. Everybody with fractures, go over here. Instead of doing it that way, we looked at the whole big picture, basically, and then we categorized them into these 4 sections. Immediate is red. So those are your priority patients. Yellow would be delayed. Green is for the minor injuries. And then the black color on the card is for deceased or basically injuries that are non-compatible with life. And I'll give you a few examples of each here in a minute. Did you know, now this one on the screen that we look at right now doesn't, but in our service, we actually have triage tags that have the color actually typed out on the card themselves for like colorblind providers. Same thing with like a Broslo tape. Those colors that are actually printed on the cards. That way anybody can use a triage tag or like the Broslo tape in the event, say they're like colorblind. Okay, immediate. So these are our critical patients, right? These patients are priority. They need to be transported to an appropriate facility as soon as possible. These patients may exhibit direct threat to life or limb. They need to be treated right away and give them a red tag. So if an example here would be like a patient with severe chest trauma, a breathing rate greater than 30 times a minute, signs and symptoms of shock. So maybe they're low blood pressure, high heart rate, increased respiratory rate. Other things that may lead the patient down that pathway would be they have significant bleeding, compromised airway, or they may be in danger of losing a limb. Okay, our next one here is yellow. So these are patients that can, the care can be delayed a little. That's why it's called delayed. They still have serious injuries. However, they can typically wait, kind of a few hours for treatment with minimal adverse effects. An example here would be like deformity to a femur, but they're responsive. There's no issues with their mental status. They're not showing signs and symptoms of shock. So even though it's a femur and that's a critical bone in the body to break, they're not obviously in shock. Now, if they had a deformity to the femur, they were altered, had symptoms of shock, you would probably tag them as red. Other examples of yellow, they may need like bleeding controlled, but they have a patent airway. Usually don't have respiratory difficulty. They're able to talk to you. They just may not be able to get and like walk or move to wherever your designated area is for these patients. The green tag. So this is for our what we call walking wounded. Usually these patients can get themselves up and moved away from the incident to your designated area. How do you guys normally, tell these patients to get up and move? Personally, I like to do it a few different ways. We do have like one of those big speakers you can talk with, like a handheld one, or you can get on the intercom of the ambulance. That way everybody in the scene can hear what you're doing in case someone's hard of hearing, and you can say, okay, everyone who is able to get up and doesn't have very many injuries, please get up and move to, and then describe where you have set up the area. Care can be delayed several hours for these patients. They still probably need to go to the hospital. Some of these patients may actually offer to help you with other critical patients. And honestly, I've had to do that myself in previous calls just because we would be waiting on resources from other counties. And, we'd have somebody with maybe a few lacerations where they're like, hey, I can help. What do you need me to do? So they may be actually to help you. And of course, all of those efforts should be coordinated with your incident command because things are different all across the United States. A few examples of this would be like isolated upper extremity trauma because they can still walk, right? So if it's upper extremity trauma, most likely that could be a minor. Cuts, little lacerations, bruises. Usually these patients are completely with it. They're responsive to commands. They're not showing any signs and symptoms of shock. So this would be considered and tagged as green. The black category. So these patients are typically deceased or have been fatally injured. So once all other patients have been taken care of, then you can utilize utilize your resources if they are available for patients who might still, say, have a pulse. We really need to be careful with categorizing people between red and black. And this is where we need to look at the bigger picture and say, does this patient, have the ability to potentially survive if we used our resources? Now, if they're not breathing, this is a big deal. If they have a pulse and they're not breathing, can we intervene? Can we do anything about that? Yes, in triage, we can open their airway and hopefully they'll spontaneously start breathing. If they do start spontaneously breathing, that's when you would probably categorize them as red or immediate. If you open their airway and they do not immediately start breathing, you may end up tagging them as black, because during triage, to make sure we're not taking our resources from other viable patients, we do not initiate ventilations. The only things that we can do, like during triage, would be, say, place a tourniquet and then open an airway. So if they're still apneic after that head tilt chin lift, then they are considered deceased or fatally injured, and you're going to give them a black tag. Here's a picture of the jump start triage algorithm. This is usually used for pediatric patients, infants, children, and adolescents. So we can kind of look at this. Are they ambulatory? Yes or no? Yes. Then obviously they'd be categorized as green, just like any other patient. If they're not ambulatory, then we look at the more critical thing. Are they breathing? Yes or no? If they are breathing, then we base it off of their respiratory rate. If the respiratory rate is good, we look at their pulse. If it's good, we look at their mental status. And any abnormalities between respiratory rate, pulse, or the mental status, they automatically are categorized as immediate, or put in the red category. If, say, they're not breathing, you can position their airway like we talked about during triage. If they automatically start breathing, that's when we would give them, tag them as immediate. If they're apneic and they do have a palpable pulse, this is where it's a little different for pediatric patients. We can give rescue breaths for pediatric patients because sometimes that will stimulate them to start breathing. So we'll give 5 rescue breaths. And then if they start breathing again, then we'll tag them as immediate. But if they don't have a pulse, obviously they're going to be categorized as deceased, or the black category. And then if they have the pulse and you give them rescue breaths and they do not breathe on their own, again, you're going to tag them as deceased. So a little different between adult and pediatric patients. The main difference is the rescue breaths. Sort first and treat later. Usually we need to conduct triage to know how much resources do we truly need for this call. We don't need to delay getting the resources to us. So conduct your triage and keep moving. You really shouldn't spend more than 30 seconds with each patient. Time is critical, because if you ended up having 10 patients, right? And you spent 30 seconds with each patient, that's 5 minutes. And 5 minutes is, in this type of situation, a long time. So if we can try to speed that process up, that's best case scenario. So again, part of the initial triage is to perform a head tilt chin lift if you don't suspect a spinal injury, or a jaw thrust maneuver for those that are suspected of having spinal injuries. Now, this may keep the patient alive until additional resources are available, but we know in medicine that if we, say, stop doing the head tilt chin lift or the jaw thrust maneuver, unfortunately, the airway is going to go back to how it was, and they may stop breathing again. So it all depends on your service if you do like opening of the airway and use adjuncts, but usually we don't. We just open the airway and move on. Tourniquet placement. If a tourniquet is needed, then and it's readily available, hopefully you carry some tourniquets on you, then you can apply those during triage. Because if you said, oh yeah, you have arterial bleeding, but let me go check on all these other patients first, by the time you come back to them, you're probably going to end up having to tag them as deceased. So tourniquet placement is important. Stop the bleeding. That way they don't decompensate and potentially pass away in the meantime. Verbal commands. So the first step in the start triage method is to ask everyone who can get up and walk to move away from the immediate rescue scene to a designated safe area. Those who actually like report pain when he or she tries to get up and move, you don't want to force them, right? Because they might exacerbate the injury. And you may have to tell them, okay, if you have pain upon movement, stay where you're at. But once everybody who can walk, once they get out of the area, then you can go sort the rest. So do not be misguided for those that call out for help. One must have a good set of lungs and undamaged brain to form words for help. That is 100% correct. So that's why these patients, if they're saying, please help me, 1, maybe they're trapped somewhere. 2, maybe they have injuries where they can't get up and walk, but they have good mental status. That may tell me, oh, maybe they're, categorized as yellow. They might be a yellow when we get to them. But don't forget to look at vital signs, because if they're showing signs of shock, that's when you're going to have to bump them up to the next category. The important part here is to look for the ones that are not speaking. Very crucial that we do a complete 360-degree walk around your scene to evaluate all angles, just in case somebody or something is missed. Because those that are not speaking tend to end up being either overlooked if you don't do a full, thorough examination of your scene, and that could potentially be detrimental to those patients. The RPM assessment. So some people don't necessarily know it by this, but they do know during triage, this is an quick and easy tool to use. So basically, we're looking for their respirations, the rate and quality of their pulse, and then their mental status. Those 3 things, along with your visual assessment, can tell you quickly what category the patients belong in. We shouldn't be taking like our cardiac monitor or blood pressures when we're doing triage, right? We shouldn't be doing that. How do we actually determine what category these patients are going to go into? Vital signs. And that's exactly what these 3 things are, is a part of their vital signs. We're going to go into a little bit more detail about each of these. Respirations. For those patients who do not start breathing after simple airway maneuvers, again, those are going to be, unfortunately, categorized under the black tag. Now, those that we are looking for that we can use our resources to treat, patients with a respiratory rate greater than 30 or less than 8, because you're going to end up tagging them as immediate. Patients with inadequate respirations, that means maybe too shallow, too deep, and then, of course, too slow or too fast. You can open the airway. Some places allow you to insert adjuncts that way to keep the airway open. Hopefully that improves the respiratory status. And if it does, then you would categorize them as immediate. If it does not, and they do not spontaneously start breathing, if it's an adult, we categorize them as black and move on. If it's a pediatric patient, we can give rescue breaths and then evaluate from there. Perfusion. So in a trauma call, where do you think the best place to check a pulse is? We want to know central perfusion, right? Look at skin color and condition. That's a great way to tell perfusion, but one of the best places to check a pulse is to go straight for the carotid. However, to check blood pressure and get an accurate idea if they are in shock, checking a radial pulse is a pretty decent idea. So if the radial pulse is absent, but there is a present carotid pulse, that should automatically tell you they're hypotensive and might be in shock. So we need to evaluate and keep on moving, right? Other things that can help you tell their perfusion status would be cap refill. It's not the most reliable tool, say for like elderly patients, but it is one of those things combined with other assessments that can determine their perfusion status. So if a cap refill takes longer than 2 seconds or there's no radial pulse, then the patient gets a red tag, right? Most likely in that patient, there's still a present carotid. If the cap refill is 2 seconds or less, there is a radial pulse, then we're going to move on and categorize per the injury, right? Because they're probably not in shock. So now we're going to look at their injuries. How significant are they? Can they move? That might determine between yellow and green. Mental status. So assessing the mental status of a patient should be as easy as walking up to them and talking to them, right? Obviously, those that have already removed themselves from the area have an intact mental status. They were able to follow commands. Those that cannot follow simple commands will end up probably receiving a red tag, categorized as immediate because they are altered. In this type of situation, we want to use the AVPU scale. So alert, verbal, pain, and unresponsive. If they are alert, then we ask them, do we get into their entire medical history during triage? No. All we need to know is they are alert, looking at us and know what's going on. If we have to kind of arouse them and get their attention by talking to them, then they would be alert to only verbal stimuli. If we have to do, any type of painful stimuli, like say grabbing the traps or anything like that, be careful with doing sternal rubs. A lot of places have gone away from doing that just because of potential for like skin tears in elderly patients. But yes, that is one of the most common ways to see if someone's responsive to painful stimuli. And then someone could be completely unresponsive. Those that can follow simple commands are usually triaged according to their injuries. Be careful. Don't let that trick you, because those that, are still thinking clearly and talking to you, they might be compensating, right? They may be in compensated shock. So pay attention to vital signs and injuries despite their ability to think clearly. They may end up being categorized as red instead of yellow just because of that. All right, and our conclusion to this section. So the START triage method is widely used among EMS workers. It's best to make sure you know what's utilized in your area, and hopefully both the EMS service and hospital are trained the same way, so everyone's on the same pathway when you bring patients into the hospital. The purpose of triage is to sort and care for patients in the order of severity of injuries. So again, use your RPM assessment, look at respiratory rate, their pulse, mental status, along with their injuries to help sort these patients. The key to managing a mass casualty is to prepare yourself. Hopefully you and your departments get together and do some mass casualty training. In our area, we do events called like Shattered Dreams, where we set up these like big mock car accidents, get everybody in the city involved. And I mean like the high school students, the city police, the sheriff's department, fire, EMS, the judge, helicopters, like anybody and everybody we tried to get involved in this situation. That way, if we train together, we may be a little bit more prepared when an event actually happens. Training and knowing your company's protocols, guidelines, and methods of triage are vital to managing a mass casualty. This next section, we're going to talk about traumatic brain and spinal cord injuries. Our objectives for this section, we're going to be able to recognize the key anatomic structures of the skull and spine, identify the components of a neurological assessment in the field. Then you'll be able to describe the signs and symptoms of a traumatic brain injury, minor neck injury, and spinal cord injury, as well as describe the pre-hospital treatment of a patient with either a traumatic brain or spinal cord injury. Before we get into the real big details about these injuries, let's talk about numbers. So here's a few statistics. Here in the United States annually, there's about 20,000 new cases of spinal cord injuries a year, and then about 2.5 million traumatic brain injuries. Now, as a healthcare provider, we know with traumatic brain injuries that covers every kind of traumatic brain injury you could think of, from, a minor, maybe like small anoxic brain injury to something that's more severe. Since 2005, motor vehicle collisions accounted for about 42.1% of the spinal cord injuries, while falls accounted for 26.7%. Traumatic brain injuries are more directly related to age. So let's think about this. If it's more related to age, specifically this next bullet point says TBIs from falls are more common in children from newborn to age 4. Well, we know with children, their heads are a bit larger. Their center of gravity is a little different. They kind of follow wherever that head goes. So they're more prone to, when they do fall, to hit their head. I have, 2 toddlers, both crazy boys, and they love jumping off of things. They love to wrestle. They love to play around and be rough. So I can 100% see how age is directly related to this. The first thing that happens, just because their head in proportion to their body is larger, that's going to be like the first thing that gets hurt. And then adults ages 65 and older. So what do we know about the elderly? We know that their balance may be a little different because of a few things. Think about vision, hearing, all of those things can affect, the elderly when they're trying to walk. Maybe they misjudged where the end of a curb was, where they didn't know there were stairs. They didn't really understand, the ground around them. So they are more prone to potentially falling. Blunt force, and then of course, think about patients who have disease processes such as like osteoporosis or arthritis or other things like that, that can make them, more prone to injuring themselves. Blunt force trauma is the greatest from 5 to 14 years of age. What's really going on in that age group? So they start school, they start getting involved in maybe some sports, youth activities. They, such as, let's think, football, for instance, right? Kids love to play sports. So if they're going to get involved in something like that, they're more likely to, in that age group to have blunt force trauma. Okay, let's talk about anatomy. So why is it so important to know anatomy? Well, first of all, you have to know what bones are affected so you can write it in your report, so you can give that information to the receiving facility. You also kind of need to know underneath that bone, like what could be affected, especially when it comes to the skull. So the skull anatomy consists of the cranium, which are 8 different bones. The facial bones, there's about 14. And then the meninges, which are inside the cranium that help keep the brain in place and cushion it. As well as, there's cerebral spinal fluid in the skull that all helps keep the brain in place and protect it. Now, when we're younger, as a newborn and infant, our skull's a little more flexible. Kids and infants have like the little soft spots on their skull because their skull's not quite fused, because they're going to grow rapidly and they're going to need that room for the growth. Eventually, those soft spots close. I want to say with my kids, both their soft spots probably closed around 12 to 14 months, around that time frame. In the event of a TBI, children's skulls will flex, which is kind of a good thing, because if it is able to flex, if there happens to be any type of swelling within that skull, then we have a little more leeway there, whereas adults don't have any room for that extra swelling that could potentially happen. So the only thing that's going to happen is the potential for the brain to completely be compressed. Spinal anatomy. So we have the cervical spine, which, let's put some numbers, right? We have a total of 33 vertebrae. So cervical spine has 7 vertebrae. Thoracic is 12. Lumbar is 5. Sacral is 5 fused. And then the coccygeal is 4 fused, bringing it to a total of 33 vertebrae. Now, a few other things I'd like you guys to kind of refresh on and take a note of would be where the skull and spine kind of meet, right? Right there at C1, C2. So the large hole at the base of the skull, that's called the foramen magnum. Why is it so important to understand, that area specifically? Is because right where it connects, that's your brainstem, right? So the brainstem helps control all of your very important life functions, such as like your heart rate, your blood pressure, respiratory rate, things like that. So to break it down a little further, I know this is a continuing education class, but it really helps to kind of refresh your memory on these things, just because say you have a patient who ended up with a traumatic brain injury and you're seeing them experience certain signs and symptoms, you may be able to narrow it down of, their brainstem is being affected, right? So within that brainstem, you have 3 parts. You have the medulla oblongata, and yes, that's a real thing. You have your pons and your midbrain. What do each of these control? So the medulla is responsible for things like vomiting, sneezing, coughing. It houses your cardiac and respiratory centers, mostly for rate, okay? It's mostly rate. So like with the heart rate, this is where, say the sympathetic nervous system kicks in, the heart rate will increase. If the parasympathetic nervous system kicks in, the heart rate will slow down, calm down some. Blood pressure, you have some baroreceptors for blood pressure here attached to the medulla. Breathing rate, again, it's based off of what? It's based off of cerebral spinal fluid. So it's almost like you taking a sample of water from a pool, right? You take it to see how acidic is it? Do we need to put any chemicals in there? Well, your brain is kind of acts the same way. It takes a sample of that cerebral spinal fluid, of those chemoreceptors, and it says, okay, you're not breathing fast enough. I'm going to need you to speed your breathing rate up. And that's specifically controlled there at the medulla. And it also helps with your sleep and awake cycle. Your pons, so this kind of goes hand in hand with the medulla. Your pons specifically is more of the movement and the rhythm of your breathing. So inhalation and exhalation, so the actual movement of breathing in and breathing out. Your respiratory rhythm, such as when we have patients who are in diabetic ketoacidosis and they are in that acidotic state, they may have Kussmaul respirations, so deep and rapid respirations. And that's because the pons is being stimulated, going hand in hand with that medulla saying, okay, this is too acidic. We need to speed up the respiratory rate to try to blow some of this acid off and get it out of our system. Your midbrain helps control things like movement, vision, hearing. So if someone hits their head really hard and they start having like ringing in their ears or spots in their vision or trouble with movement, you may think, well, that might be the area that's being affected. Mechanisms of spinal cord injuries and traumatic brain injuries. So since we're talking about anatomy, let's go ahead and look at how this affects the organs under all the bony structures, right? So that violent impact to the head can cause not just injury to the skull itself, like the bones, but it can cause issues such as swelling. So swelling of the brain and that extra fluid could actually be detrimental. And I'll talk about that here in a second. A mild injury can cause temporary dysfunction, whereas a more serious injury can present with long-term injury or even death. So mild injuries, I think we talk about, signs and symptoms later on, but think about events where there might be a mild type injury. Again, sport injuries, maybe that might be more on the minor side. I mean, there are a lot of kids that take hard hits, especially during football, and that could actually paralyze them. But like when hitting their head, they have helmets on and stuff like that. So that might be a little bit more on the mild side. A more serious type injury could be due to like a car accident or a fall from a significant height, right? Damage to the spinal cord, vertebrae, ligaments, or the disc of the spinal column can cause permanent weakness, loss of sensation, or decrease in body functions. I don't know how you guys feel about like chiropractic care, but this is kind of on the same basis of if you have any type of pressure or swelling or anything within that spinal column and it's pushing on that spinal cord, think about how it's going to affect your body functions, right? Our brain likes to send messages to our body organs of what to do, how to function, how to operate. If there's a disconnect or there is, an issue where the messages aren't getting sent back and forth effectively, you can have issues like trouble with going to the bathroom. That's a real common one. Numbness and tingling in toes and fingers. Even like permanent things like difficulty with breathing. And patients may end up having to be on like a ventilator the rest of their life. And then, like I said a second ago, that additional swelling and bleeding can cause issues around the brain and can cause issues around that spinal cord, making that damage worse. And unfortunately, if that swelling, especially in the skull, if the swelling gets so bad, what's going to happen? Well, path of least resistance is that foramen magnum at the base of the skull, and that swelling could actually shove the brain downward right out of that hole. So it could herniate through that foramen magnum. And of course, that's going to be incompatible with life. Here later, when we start talking about vital signs, we'll talk more about how to pick up on that before it gets to that point. All right, neurological assessment. Performing a full neurological assessment as quickly as possible is vital for establishing a baseline for comparisons during ongoing assessments of the patient. That I wanted to read verbatim because it is extremely important to get that baseline. How can you compare and see if the patient is getting better or getting worse if you haven't established that baseline? This is something that you can also, when you write in your reports and you're going to give to the receiving facility, they're going to look at the trending pattern to see, okay, is this getting better? Is this getting worse? What are we thinking here? With doing the full neurological assessment, usually we use like the Glasgow Coma Score. Plus, you can check pupils. Other items like here it says we're going to use the AVPU scale, and we're going to see, are you completely alert? Are you only responsive to verbal stimuli, responsive to painful stimuli, or are you completely unresponsive? So if a patient, which I caution you when you try to see if they're, responsive to painful stimuli, be careful doing the old school like sternal rub, just because, elderly patients, you may cause skin tears or something of that nature. So what I like to do is kind of pinch the trap just a little. I don't know if your mom, when you were a kid, ever like grabbed a hold of your trap and kind of pinched it. That's not too pleasant, but it's not it's not pleasant and it's not too painful. It'll definitely make somebody respond, and it's a little better than creating skin tears. Think about other assessment items that we can that relates back to either a traumatic brain injury or a spinal cord injury. Respiratory effort, right? If they get hit above like that C5 area, it may end up paralyzing and making the diaphragm to where it's paralyzed and won't function. So they may have severe difficulty in breathing, and you may see them either try to, only the upper part of the chest might be moving. What about bladder and bowel control? Those are all things that can lead you down the path of maybe this patient does has a significant injury. When we use the Glasgow Coma Score, you just kind of have to have that chart memorized, right? Which I've been in EMS for quite a while now. I have that chart memorized. We use it all the time, regardless if it's a medical patient or a trauma patient. We do that. That way we get used to getting a GCS on a patient. At least that's how our medical director is. He's like, it doesn't matter if it's medical or trauma, to know the GCS on your patient is extremely important. And it's great for your reports as well. So it's widely used, and it helps communicate like on the same level between like healthcare provider to healthcare provider, the level of consciousness of the patient. So the scores between 3 and 15. Think about this. So the wall behind me, what would the GCS of it, what would it be? It would be 3, right? Why is that? So here's the chart. Here's a cool chart here. EVM, which is eye-opening, verbal response, and then motor response. And then it's 4, 5, 6 for the total numbers. So the wall doesn't have eyes, so it's not opening its eyes. That would be 1, right? I still get a point for that. Verbal response is not going to talk back to me, so it gets another 1. And then motor response is not moving, so that would bring your score to a total of 3. So like the rocks on the ground, anything like that, a GCS would be a 3. Now, where it gets a little difficult is just trying to remember, each step of this GCS scale. For me, this is how I kind of do it. So under eye opening, the 4 is like the AVPU scale, right? Are they alert and spontaneously looking at you? Are they only alert to verbal stimuli, painful stimuli, or are they unresponsive? Once we get to the verbal, this is where I kind of, if you just start with normal and then trend it downward, whereas you have a normal conversation, so it's 5. Number 4, they're still talking, like they still can produce words, but it's disoriented. That's how I kind of make the difference between 4 and 3, because they're more pronounced words. They just make no sense. 3, there are some words, but it's kind of slurred together or not coherent at all. Number 2 is no words, only sounds like grunting, moaning. And then, of course, 1 would be none. Motor response. So for a patient that has normal motor response would get a 6 for that. 5 localizes to pain. So they can kind of, show you where it hurts. 4 withdrawals to pain. So if they're unconscious, unresponsive, or they're just like responsive to pain and they're kind of rolling around and moaning, and you do something, they pull away, right? They pull away because it hurts. So that would be a 4. And then we have our posturing patients. Decorticate, which decorticate posturing is like the arms and the legs like toward the core. Everything turns inward, decorticate. And then 2 is decerebate, so like away from the cord or away from the core. I know it may sound funny, but decerabate's like celebrate. So yay, you like put your arms out to celebrate. I know that may sound funny, but that's how I remember it. And then of course, if they're posturing like that, that's a pretty significant injury that they're having. And then of course, if they don't have any type of motor response, then that's going to be a 1. Normal GCS is 15. And remember, your treatment's going to be based upon your findings, right? Traumatic brain injuries. So they can be classified as either mild, moderate, or severe. It's mainly based on like their presentation. Think about the time frame of when the injury happened, and then their signs and symptoms, right? So mild, they may just be a little confused, maybe a little taken aback, but there's usually no loss of consciousness. Now, if there is a loss of consciousness, it might be for a few seconds or up to maybe a few minutes, but usually they're like, no, I don't think I lost consciousness. Some people may be like, I'm not 100% sure if I did. I might have. And that's when they may have, say, their passenger or somebody say, yeah, you did lose consciousness for about 30 seconds or so. Moderate injuries. So usually you'll see loss of consciousness for a few minutes up to a few hours. Long-term confusion, and then long-term effects like physical effects, cognitive, behavioral deficits, and those may be permanent. You just have to think about where's the damage at. If we don't have good blood flow, or if there's injury to a part of the brain that controls movement or physical functions, thinking, and then like your personality and the frontal lobe and your behavior, you can have actual outward signs and symptoms of that. Severe, obviously that's caused by like violent impacts or penetrating wounds to the skull, or to the skull. Usually those are life-threatening, and usually trying to get back to normal, like their full 100% self before the injury, is very rare if they've had a traumatic brain injury like this, which you can see those pictures over there. Those are pretty significant. So trying to get back to how they used to be before that is going to be extremely difficult. One thing I want to point out, and this happens all the time in EMS, I've seen it numerous of times in my career. On calls that you suspect any type of brain injury, I don't care if it's little, might be like a concussion or However small the injury might be, transport these patients. Don't just try to get out of a report or do, a refusal. Take them to a hospital. So many times, their adrenaline's pumping. They want to refuse care and go home. Maybe they don't want the bill. Maybe they don't want to sit in a hospital. They think they're truly fine. But then what happens? They may go home, go to sleep, and not wake up. Who knows? They may have had a little brain bleed we didn't know about and couldn't see until, unfortunately, it was too late. So I recommend that if you can get these patients to go to the hospital, which I know we can't force everybody, we can't kidnap them, but if you can try to convince them to go to the hospital, then that's going to be beneficial to everyone in the long run. Here are some examples of different types of TBIs or traumatic brain injuries. Contusion. So this is bruising in the brain. Usually this happens with kids who play contact sports such as like football. They're definitely more at risk for contusions for sure. Coup contra coup injuries. What is this? So this is a result of multiple impacts within the skull. Okay. Say you get in a car accident. So the car makes an impact, right? And everything in the body is going to end up impacting into the structures of what's protecting the organs. And unfortunately, so say the body goes forward. What happens to the brain? The brain's basically going to slam the back of the skull. It's going to slide backward. And then when the body goes backward, because say the car got hit again or it slowed down or whatever the case may be, then the brain's going to hit the front of the skull. So now you have bruising or injury, even potentially bleeding on both sides of the brain. That's why, again, if you can try to convince these patients to go to the hospital, because we don't know exactly how the, say, car accident or injury took place per se, we weren't there, they need to go ahead and get checked out just for caution, right? Diffuse axonal injury. I hope you never have to deal with something like this in your career. I've been in EMS for quite a while, and unfortunately, I've had to work 2 shaken baby syndromes. And they both had a significantly telltale sign that this was shaken baby syndrome. So when babies, are shook, think about how soft, all the tissue is super sensitive, right? The brain could bleed. What are some typical signs and symptoms of shaken baby syndrome? Well, they're lethargic. They might, if they're still alert, they might be confused or crying or whining and you can't console them. They may even be unconscious and the parent is trying to say, or whoever is with the child is trying to say, oh, they're just sleeping. That's why when you do pediatric assessments, personally, I understand you think they may be sleeping, but I'm going to wake them up to make sure we get a baseline assessment to see what their mental status is. That way we don't, accidentally miss something and then they pass away for whatever reason because we didn't step in. So other than those signs and symptoms of being lethargic and crying, I may even have blood from the nose or ears or something like that. When you suspect abuse, please, 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 please look at the baby's eyes, okay? The sclera, the white of the eye, is super sensitive. All those blood vessels are very susceptible to bleeding. And they're more susceptible from non-accidental trauma, right? All of us get maybe some busted blood vessels from allergies or rubbing your eye, or maybe you wore your contacts too long. But children, you know, and when I'm talking about busted blood vessels, I'm not talking about just like the little allergy type ones. The entire sclera might be either solid red or it may look like they've been up on a drug binge for months. It is an awful, awful view to look at a baby's eyes and see, you know, the sclera so red because of ruptured blood vessels. And this is how I was able to identify that something more significant went on during these 2 calls I had to work. And I was able to stay calm. And luckily, police were there, and we had the police separate the caregiver while we were trying to take care of the baby, and ask them more questions. That way, you know, safety reasons, we didn't get involved in anything, and they tried to come after us for whatever reason. So, and that's called a diffuse axonal injury, usually from severe shaking of the head. Types of intracranial hematomas. So when we see patients with brain bleeds, do we really know if they have a brain bleed pre-hospital? Typically not, unless it's like the obvious things like abnormal and unequal pupils. And even then, we don't even know if it's actually blood that's in there, right? So the only way we can do that is get them to a center that has, like a hospital that has neurology on site, and to where they can do a scan, like a CAT scan on their head or something. So really depends on where the bleed's at. An epidural bleed, so this is above the dura mater, which, you know, that's between the skull and the outer layer. The outer layer is that dura mater. Usually it's caused by a skull fracture, can be near a large artery or vein. It doesn't necessarily have to be just an artery. It can be both an artery or vein. Usually these patients have like an intense headache that rapid onset, but like when it goes away, it returns with rapid loss of consciousness. Subdural hematoma, so this is beneath the dura mater, so the outer layer and middle layer covering the brain. That's where the bleeding is at. Usually caused by like a venous bleed, but it could be from an artery. More common with a subdural bleed is for venous bleeding. Symptoms can develop rapidly or slowly. Just really depends. I would imagine, is it a venous bleed? That might be a little slower. Artery bleed might be more rapid. This is common in the elderly, alcoholics, and those on blood thinners. Subarachnoid. So this is between the brain and the membranes covering the brain, that arachnoid layer. So it's definitely low, like further in the skull. And those are more deadly types of bleeds for sure, are these subarachnoid ones. They're rare, but they're more deadly as well. Acquired brain injuries. So this is damage that's from an external, or that's not from an external force. So for example, a patient who has a stroke, maybe they have a tumor, anoxia, hypoxia, toxins, degenerative disease, and near drowning. So let's go through some of these. Anoxic brain injuries. This is when there's no oxygen reaching the brain at all. Complete cut off. Those oxygen molecules are not getting to the tissue to perfuse it. And that could be from a stroke. My best friend, one of her family members actually had COVID, and they didn't catch how low her oxygen saturation was, and she ended up with an anoxic brain injury from the lack of oxygen due to having COVID. Luckily, she's fine. She has some serious deficits, but we're thankful she's still with us. Anemic anoxia. So this is where low oxygenated blood, like the actual hemoglobin, there's not very much that actually reaches the brain. This could be to like loss of blood. So we don't have enough of the red blood cells and stuff to circulate to get the oxygen where it needs to go. Toxic anoxia. So toxins that end up reaching the brain and block the ability for oxygen to perfuse the tissue. An example of that would be, say, like carbon monoxide, right? So carbon monoxide can actually bind to the hemoglobin and tell oxygen, I'm bigger and better than you. Sorry, this taxi is taken. You can't have it. So now all the hemoglobin end up being saturated with carbon monoxide, but that's not going to perfuse the tissue, right? It's not. And the crazy thing about that is if you put them on a pulse ox, so pulse oximeter to check their oxygen levels, it'll say like 100%. Why is that? Well, think about it. A pulse oximeter doesn't actually pick up the molecule itself, right? It doesn't say, this is an oxygen molecule or this is carbon monoxide. It uses infrared light to just see if the hemoglobin are saturated. That's why it's a saturation. What is your O2 sat? Your saturation is just to see, how many of the percentage of the hemoglobin actually have something attached to it. So it's tricky because you can have a patient who's been exposed to carbon monoxide, but they have a perfect pulse ox. So think of the other signs and symptoms these patients may have. Rosy red cheeks, a headache, the whole house is sick and have headaches. You probably need to get them out to a well-ventilated area. That way you don't become a patient as well. And we all know if, say, there's like a gas leak or something, that could be dangerous not only to breathe it, but there could be a potential for like an explosion. So later on. So for sure, try to get these patients out to like a well-ventilated area. Hypoxia, that occurs when the brain receives limited oxygen due to the reduction of blood flow or blood pressure. This is why it's important for patients who are exhibiting signs and symptoms of shock to be treated. If they are hypovolemic and need fluid, if they're, really anything. It could be a traumatic injury. It could be a medical situation where you have like a fluid shift, where now the fluid is now in the interstitial space and it's not in the vessels where we need it to be. So patients can actually become hypoxic that way. Here are some signs and symptoms. So there are a few slides related to signs and symptoms, but we're going to separate them by general symptoms to, I think, sensory and then cognitive as well. So general symptoms would be like loss of consciousness, could last, again, seconds to minutes. Just depends on how severe the injury is. They could be disoriented, not really know what's going on, confused. They may be repeating themselves over and over. Headaches that are persistent or are worsening. So even if you end up or you get called to a house for someone who has a severe headache, I would want to know, was there something earlier on in the day that could potentially, say you hit your head and now this is a brain bleed? We probably need to get you to the hospital, right? So getting a good history on these patients is important. Nausea and vomiting, anytime someone has pain, especially to their head, that can make someone nauseous and want to vomit. Fatigue, pain alone will make somebody very tired. More signs and symptoms. Ooh, this is a lovely picture of the unequal pupils there. I'll talk about that in a second. So drowsiness, dizziness, seizures even, loss of balance, dilation of one or both pupils. So quick story here. My oldest son was born 7 weeks early. And so I was 33 weeks pregnant when I had him and had to have him by emergency C-section. He went to the NICU for 6 weeks. He's fine, all that good stuff. But the crazy thing is, when they were going to release me from the hospital, I noticed one of my eyes was really fuzzy and I couldn't see out of it very well. This was before I had my Coke bottle glasses here, but I couldn't see out of it very well. So I went to the bathroom and I was like rubbing my eye and looking at my eyes. And I was like, am I seeing myself correctly? I had unequal pupils. And being a paramedic, I was so confused. I was like, wait, start doing like a neurological assessment on myself. I'm fine. What in the world could this be? So I called my doctor. I said, hey, I know I may sound like a Fruit Loop, but can you come please check me out because I have unequal pupils and I can't really see out of this eye too well. They started to kind of freak out. My doctor came in there and assessed me and was like, we need to get neurology over here. I hope you're not. Of course, she was able to talk to me like a normal healthcare provider. She's like, running through the whole list of what it could be. And then so she leaves and I'm sitting there just still thinking, what in the world could it be? Well, she called me back and she called in the room and said, Alex, did you have a nausea patch behind your ear? And I felt behind my ear. I was like, I did. She's like, what did you do with it? I threw it away. I took it off and threw it away because it was kind of bothering me. And she's like, did you wash your hands afterwards? Or did you happen to touch your eye maybe? And I was like, you know what? As I'm rubbing my eye, maybe I did rub my eye. So funny thing is, I got the medicine on my fingers and ended up touching my eye and it dilated my pupil. So yeah, how crazy is that? That nausea patch caused one of my eyes to be dilated. I thought that was super interesting. Other symptoms could be drainage of clear fluids from the nose or ear. That could be significant, right? That could potentially be like cerebral spinal fluid. Difficulty waking, so you can't arouse them, can't get them to wake up. Numbness in their fingers and toes. Sensory signs and symptoms. Blurred vision, ringing in the ears. Remember what I said about what could potentially be damaged? That midbrain, potentially, with hearing and vision and movement. A bad taste in the mouth. So usually people complain of like a metallic taste. Smell changes or sensitivity to light or sound, known as photophobia or phonophobia. Cognitive signs and symptoms. With the memory changes, this could be difficulty learning new information following the onset of amnesia. So, that's obtaining new information, right? Difficulty remembering past events and familiar information, retrograde amnesia. Oh, anterograde amnesia is the difficulty learning new information. Retrograde amnesia is previous information. Patients could also have mood changes. They could experience depression or anxiety, have extreme confusion, agitation, be combative. So remember, don't take this personally when you're treating these patients. They probably don't know what's going on and you're just going to have to deal with the agitation, or if they're trying to hurt you. That's where you may have to, like if A-list providers may have to sedate and calm these patients depending on your protocols. Slurred speech, and they could potentially even be in a coma. let's discuss some pre-hospital treatments. First of all, we want to make sure we monitor these patients very closely, especially if they're critical. If they're critical, my eyes personally don't leave the patient just about. Maybe to grab some equipment, but I am constantly assessing and reassessing these patients. In our books and everything say critical patients reassess every 5 minutes. Stable patients reassess every 15 minutes. That's all fine and dandy, but I am constantly visualizing, is the patient deteriorating or not? Now, when it comes to the time frame, I'll just set my monitors up to cycle the vital signs every either 5 or 15 minutes, just depends on the patient I'm dealing with at the time. So monitoring the patient's blood pressure, heart rate, respiratory rate, all of those things are important, as well as like their oxygen status. You don't want them to become hypotensive, and you definitely don't want them to desat. You don't want their oxygen levels to go and decrease at all, because that can increase the mortality rate significantly. We want to pay attention to airway. They may need you to take over their airway or assist their ventilations or just provide oxygen. Just depends on how severe. Obtain IV access for ALS providers. That would greatly be recommended. You may end up having to give medications, especially if they're hypotensive. Administer medications. Rapid decision of transportation can prevent further injury. We don't need to let the grass grow. Sure, we need to go ahead and finish our assessment there on scene real quick, just to make sure we don't exacerbate anything when we go to move the patient. But we don't need to sit there all day and talk about the patient's whole life story. We need to package them and get down the road. We can ask other questions later if need be, or assign that to somebody and have them get it while you get on the road. And then, of course, take them to hopefully a facility with neurology on board. Spinal precautions should be taken for all patients with traumatic brain injuries. As if they have a traumatic brain injury, again, you may have to ventilate, you may have to, do anything like that. And it's even suction. It's easier to do that when they're on a board, for one. And two, they might have a spinal cord injury with the traumatic brain injury. I know how everybody is with like backboards these days. It's more rule in the backboard versus rule out. Because it's like, oh, you have these certain signs and symptoms, so we're going to go ahead and use a backboard. Whereas old school, when I started in EMS, we used a backboard for every single patient that was like in a car accident. It didn't matter how small of an accident it was. We basically used a backboard, cervical collar, head blocks, strapped them all down on everybody, right? We did that all the time. But now that actually can cause more damage than good sometimes. It just depends on the situation. And one of the biggest things is putting somebody on a backboard can decrease their respiratory effort. And that's kind of why we've gone away from every single patient needing a backboard to now we just rule it in depending on, for this example, you have a traumatic brain injury or a spinal cord injury. Let's go ahead and use a backboard. Airway. So here's one I was telling you guys. If your patient desaturates, that can significantly increase the mortality rate. So if apnea briefly occurs, which it can, in most head injuries, you do have a change in that respiratory rhythm that can cause arterial desaturation. If the patient has a drop in oxygen, that actually correlates with a 50% increase in mortality rate, and then a 50% severe disability in survivors. So if they do survive, if they had a drop in that oxygen, that might be a cause of why they're disabled, why they have more severe disabilities than if that oxygen drop would have been caught or maintained. Provide supplemental oxygen if you can. Get that saturation greater than 90. I know a lot of places, just depends on your protocols. I know a lot of places aim for that 94% and above. So make sure you just follow whatever your medical director wants you to do. If intubation is indicated, again, follow your protocols. Some places I know took away intubation for ALS providers, and some places like here in Texas, we even have like our advanced EMTs and our paramedics still intubating. We've kind of gone the route of, instead of RSI, rapid sequence intubation, we're doing more DSI, delayed sequence intubation, where we're doing a little bit more pre-oxygenation, getting things ready and not speeding up the process to where we could potentially make a mistake. And then pre-oxygenating our patients before intubation is excellent. Intubation may be called for those that are unconscious, can't protect their airway, whether it's because they are vomiting or they have airway trauma. Blood pressure and circulation. Try to stop all visible bleeding. I know we're talking about traumatic brain injuries and spinal cord injuries, but if you have laceration on the limb and it's like arterial bleed, stop that. That way, if this patient does have a TBI as well, they still have enough hemoglobin to circulate the oxygen molecules. Because a patient who has lost a significant amount of blood, even if their pulse ox says 97%, it's only 97% of what's left over, right? So we want to try to push that up to 100% oxygen just because of how much blood they may have potentially lost. A single episode of hypotension during pre-hospital treatment of a patient with a TBI doubles that mortality rate. So stopping the bleeding, getting IVs on board, hopefully you get some large bore IVs, and provide them with fluids to keep that blood pressure up. That could help. An isotonic solution may help reduce brain swelling, but be real careful with patients. Make sure you always assess those breath sounds too, right? Because some patients might have some cardiovascular issues to where you have some pooling of fluid within the lungs, but we do need to stabilize the patient the best we can. If that's an issue, we may opt to use vasopressors, and vasopressors are still an excellent, an excellent alternative to fluid administration if you think you might accidentally provide too much fluid. If fluid overload is imminent, then I may just be like, I'll put a little, maybe like TKO, but I'm going to use some vasopressors to get your blood pressure up. Okay, spinal cord injuries. This is a little different, right? So it's not the brain itself that's being damaged. It's within the spinal cord, within the vertebrae. There could be a complete severance of the spinal cord. If that's the case, there's going to be complete paralysis or loss of feeling and movement below that injury level. Like I said, if you're up in the cervical spine, you may lose movement to that diaphragm, and patients may have to be on a ventilator the rest of their life. If it's incomplete, those injuries kind of vary with signs and symptoms. So let's discuss those signs and symptoms now. Loss of movement completely, so that's paralysis. Loss of sensation, paresthesia. Loss of bowel or bladder control. Exaggerated reflux or spasms. Changes in sexual function, sensitivity, and fertility. And we know in males, if they have a priapism, that's a sign of a significant spinal cord injury. difficulty breathing or coughing. If you look at these pictures, here's a few examples of other signs and symptoms. If you see bruising behind the ears, that may indicate a basilar skull fracture. With that being said, match it with this picture where you see blood on the sheet there with like kind of a halo around it. So there might be bleeding from the ears as well. And the halo is the cerebral spinal fluid, which obviously that's a pretty significant injury. You may see a patient with bruising on the eyelids or right underneath the eyes, as we know as like raccoon's eyes. All of those may not be necessarily apparent right away. So that's why during your assessments, your reassessments, you need to make sure you pick up on these things in case they start to develop during transport. Acute signs and symptoms. So something that comes on quickly: extreme back, head, and neck pain, weakness, lack of coordination, paralysis in any part of the body, numbness, tingling, difficulty walking, impaired breathing, or if they have like an obvious oddly position or twisted neck or back. You got to be careful. You probably want to keep them in that position. Don't move them because you don't want to exacerbate the injury itself. So this is why it's important when we're doing our assessment and we get down to the limbs that you're asking these patients, can you feel me touching you? Can you wiggle your fingers? Can you, wiggle your toes? Can you feel me touching you on your feet? That way, one, you've assessed sensation, you've assessed actual movement, so that's intact. And of course, if they have fractures, you don't want them to really be moving their limbs and exacerbate that, but you still need to kind of, if they just wiggle their fingers a little and they can say that, yeah, I can feel you touching me, those are good signs. That means we may not necessarily, this patient may not have, too bad of a spinal cord injury because it's still intact. The things I'd be concerned about would be like, if this patient does have numbness and tingling, to be real gentle and move this patient easily and probably package them on a board. Here's a few things with pre-hospital treatment when it comes to spinal cord injuries. So we all know the spinal cord does control the sympathetic and parasympathetic nervous system. So the sympathetic is our fight or flight, so epi or norepi. Parasympathetic is that feed or breed, so acetylcholine. It's the vagus nerve response, right? In high-level spinal cord injuries, the patient's parasympathetic system will be unrestricted. With the inability to counteract it, the patient would not be able to compensate with vasoconstriction or an increased heart rate, causing distributive shock. So then we have neurogenic shock with these patients, right? Initially, these patients might present with hypertension, and then eventually everything goes downhill from there. When it comes to traumatic brain injuries, they may end up developing Cushing's triad. So this is where a patient would have like severe hypertension, and I'm talking like 220s over 110s. We don't really want to treat hypertension in a brain injury like this, right? No, it's the body's natural functions, right? The blood pressure is going to increase. The heart rate's going to be low. So it's going to be bradycardic, maybe around like the 40 mark. Irregular respirations. And there's a pattern to those are irregular respirations. It's called the Cheyne-Stokes respirations. Treatment for this, and the reason Cushing's triad happens is because that brain is being squeezed so tightly that it's going to end up herniating. And those are signs and symptoms of potential brain herniation. So we need to pick up on that and get them to a center with a neurology quickly, because the treatment is going to be either craniotomy. It really depends on your protocols. I remember when we used to hyperventilate all of these patients. Just make sure you follow your protocols. Mannitol. I don't know if you guys have ever used mannitol before, but I've seen it work pretty decently on some patients. It works through osmotic diuresis. So basically it draws out the edema out of the cerebral tissues to help decrease that intracranial pressure. It'll also improve, the blood flow, and it can be used in patients with like traumatic brain injuries. But that medication needs to be monitored very carefully. I honestly don't know any ambulance service, at least around this area, that even carries that anymore, if at all. So just make sure, you follow your protocols, of course. Other treatments. So upwards of 25% of spinal injuries occur after the initial damage. That could be when we're handling these patients, or it could be when they self-extricate themselves out of a vehicle and they're walking around. Patients with a spinal cord injury above C5, like I said, will present with respiratory failure. That diaphragm will fail. It won't work. Spinal mobilization is standard of care for patients with suspected spinal cord injuries. Again, think about, what are your protocols in your area? Do you use a backboard? Do you not? I know a lot of people are like, can you walk? Walk to my stretcher. But if you suspect a spinal cord injury, that's the best thing you could probably, do until you get to the hospital, is get them on a backboard, do some motion restriction with, strap down their torso, their legs, make sure they have a cervical collar on, strap down their head last, assess their CMS, their circulation, motor function, and sensory before and after strapping them down, and then get them to a center with neurology. So the point of treating shock would be to maintain perfusion, right? We need to maintain perfusion. How do we know we're doing this? Well, look at vital signs. We can maintain a mean arterial pressure of at least 60 and above to maintain tissue perfusion. That's a minimum. Now, say you have like a septic patient, that's when we're looking at that map of 65 and above. Now, your protocols and medical director may have different numbers, but that's usually national numbers. Being able to recognize that this patient is in shock is vital for a patient's outcome. Starting large bore IV, so like 14 or 16 gauge, followed by fluid bolus, is pretty normal. Use like normal saline or lactated ringers. Just be careful. So usually fluid is like 20 mLs per kilogram until you get to about, again, protocols, 90 to 100 systolic. For pediatric patients, you're looking more at that 5 to 10 ml per kilogram. Slowly, careful with the fluid overload. And just pay attention to your patients constantly. Vasopressors should be used if no response to fluid bolus or if patients are at risk for like the fluid overload. Personally, dopamine is one of my favorite meds to give just because I understand how dopamine works. There's other options like norepinephrine, so Levophed, phenylephrine, all those, it just really depends on what you carry on your ambulance. Real quick, so dopamine, a lot of people don't like using it just because it's such a wide range of doses. And that's why I like it, because it gives you different effects in the body. So dosage 2 to 20 microgram per kilogram per minute. Well, we don't want to dose under 5, especially if they're hypovolemic. We don't want to do that because that's called renal dosing. We're going to end up dilating that renal artery, and they're just going to actually urinate the rest of their pressure out. So don't dose under 5. If you do start at 5, know what's happening in the body. You have more beta effects. So remember our alpha and beta effects in the body. Beta effects, this is where the heart rate's going to be affected. It's going to increase the heart rate. Is it going to do much for pressure? Not much, not at 5. Once you get to 10 microgram per kilogram per minute, you're going to see more alpha and beta effects. So at that 10 microgram per kilogram per minute, you're going to get more alpha and beta effects. So you're going to see an increase in blood pressure. You're going to see an increase in heart rate. So those are your shocky patients, right? Hypovolemic and potentially bradycardic. If you're going to dose 15 to 20, you're going to see more alpha effects. So it's going to increase that pressure without changing the heart rate too much. So high heart rate, low blood pressure, that's more of your compensated shock. It's not going to mess with the heart rate too much. So it's okay. You can start at 15 to 20 with those patients. But like I stated, just make sure you follow your protocols. I personally like dopamine just because I know at each step what it's really going to do, and I can watch for those effects to take place. Now, Levophed or norepinephrine is a very potent. So Levophed, norepinephrine, is a very potent alpha-beta agonist. What it does is it causes vasoconstriction, and it'll help increase blood pressure. It is usually given for like severe type shock. So severe hypotension or bradycardia, and the dose there is usually like 2 to 12 micrograms per minute. Phenylephrine infusion, so it does have strong alpha effects. So we're going to have an increase in peripheral vascular resistance, and blood pressure is obviously going to increase. In turn, it's actually going to help decrease cardiac output and renal perfusion. So be a little careful with that. Usually I think that dose is 100 to 180 microgram per minute, and then you just titrate. Or you do, I think it's the actual weight base is 0.5 microgram per kilogram per minute, and then titrate that one as well. So just make sure you know your protocols. And then if you're, a BLS provider, the main thing is to either get them to a center with neurology or call for ALS intervention to assist you with these patients depending on your transport times. Treatment with steroids. While not widely commonly used, steroids can be administered to these patients. Now, I remember when we used to administer this all the time, and then all of a sudden it got taken out of our protocols. So methylprednisone, solumedrol, usually is administered within 8 hours of injury. Now, it really depends on how your area really feels about that. If you have a short transport time, you may not even mess with it and let the hospital, provide steroids if need be. Due to vasodilation, spinal cord injury patients are at risk for hypothermia. So make sure you pay attention to their temperature, keep them warm, covered up. Because they could also be, hypovolemic at the same time. Conclusion to this section. Quickly identifying and treating patients with traumatic brain injuries and spinal cord injuries is vital to a positive outcome for the patient. Pre-hospital providers can help minimize the effects of TBIs and SCIs by maintaining good assessment and treatment skills, and then transporting them to an appropriate facility in a timely manner. If we're able to complete on-scene stabilization, and then treat them appropriately, get them to a good center, usually these patients will have better outcomes if they have TBIs or SCIs. Well, this concludes today's class over traumatic injuries at the ALS level. Again, my name is Alexandra Rowe, and I hope you enjoyed the presentation. We appreciate your business and have a wonderful day.